and variable sign symptom complex. The clinical progression occurs over years, and the goal of the therapies that we're looking at is really stabilization or delay of neurological disease, in contrast to thinking about trying to reverse it. And optimal therapy actually may require pre-symptomatic treatment. So when you think of those issues, from a statistical standpoint, it's very difficult. We have a low N, or number of patients, a large standard deviation, that's the variability, and a small delta. The changes are slow. We understand that to parents, these changes are fast, and but in reality, the clinical progression of this disease, as you know, occurs over years. So the day-to-day change is minimal. The yearly change is even small. Okay, so we started working, when I say we, my team at the NIH, we started working on NPC in 2006. And we started with what we refer to as the NPC natural history trial, or you could refer to it as an observational trial. We've enrolled 139 individuals to date. And I actually went back to my original slides to pull out what our goals were for this study when we started. And the first goal was to identify either clinical or biochemical markers that could be used as outcome measures in a therapeutic trial. And the emphasis when thinking about getting drug approval has to be on clinical outcome measures. We've done a lot of work on biomarkers, as the community is aware. That's more to provide us tools to help guide us and to try to understand different aspects of the disease. But with respect to getting drug approved, you have to focus on the clinical outcome measures. Are you having a clinical impact? Our second goal was really to identify a biochemical marker that could be used for diagnostic testing or screening. We did this because we knew there was a diagnostic delay of about 4 to 5 years. That's from the time that the parents recognized that their child had a problem to a diagnosis actually being made. And as I think most of you are aware, we have developed in collaboration with Dan Ori's group, a blood-based diagnostic test, and that's been extended again with Dan Ori's group and with a lot of help by parent organizations and parents to a newborn screen. The focus was this was really a discovery trial. This was not designed at the start to systematically collect the same data at every time point with the idea of it being a control for a therapeutic trial. However, it does have use. This is data that we recently published. I think we've shown it to the group. It was presented at NNPDF and APMRF meetings. What we were doing here was looking at our natural history data and evaluating it for factors that influenced progression of disease related to swallowing. And we had 2 outcome measures, this overall swallowing ability, or ashenomes. That's a clinical characterization of a child's swallowing ability. And then we were actually quantifying an aspiration risk based on the barium swallows studies that we had. And working with statisticians, what we were able to show is we were able to model probability curves of increasing impairment in the clinical swallowing assessment and increasing risk of aspiration. And on the top part of this slide, what you see is the data from the patients who were not on miglustat. And on the bottom, you see the data from patients who were on miglustat. And what you can see is when we look at the individuals treated with miglustat, these curves shift to the right, meaning that miglustat delayed between these two groups, delayed the progression of impairment on both of these outcome measures. A major point to make is look at the duration of follow-up. We had data over 5-10 years in patients. We had to put all the data together from all the patients. But to really show this effect, you can't show it in 1 year. If you went to 1 year here,
Denny, we
you're not
can't
going to see any difference.
the next slide. Can you forward? We don't see this slide with the miglustat. It's still on the natural history trial.
Oh, that hurts really bad. I've been using the pointer all over the place, guys. I'll stop sharing and reshare.
All right, sorry about that, Denny.
Okay. Okay, is it up there now?
Yeah, we see it.
Okay. Does anybody want to give me a vote whether I should go back over this or whether the verbal description was there?
I would go. We can see how your entire like format. So
okay.
But yeah, I would go over it one more time.
Okay. So what this was again was the study, the two outcome measures, the clinical study and the aspiration risk based on the barium swallows. Two groups of patients, those on miglustat in the top here, and those not on miglustat on the top, and those that were on miglustat on the bottom. And these are probability curves. As you go up in probability, increased probability of having increased impairment. Okay, so for example, as you go up a lot, this is time in years, and as you go up, there's increased probability of somebody at 2 advancing to the next higher level type of thing. What you can see here is when we look at the group of patients that were on miglustat, these curves are shifted to the right. In other words, the probability of advancing in severity based on these two scales is delayed in the individuals on miglustat when compared to individuals not on miglustat. And the final point I was making was that to see this, however, it takes years. If you looked at 1 year here, you're not going to be able to tell anything. But you start getting out 5, 6, 7, 8 years, and you can see how these curves shift away from each other. That's a factor of the disease progressing relatively slowly. Okay, did my slide advance? Just double checking.
It did, but you're still like not in presentation view or whatever. And we can see the next slide, probably what you're seeing, but I do see it.
Okay. Sorry about that. How are we now?
Okay, now you're on the make list, the slide you just presented.
Okay. Okay.
Oh, great. Okay, we're good. We got it. We got it.
Okay. Second talk today, guys. Okay, so what about hydroxypropyl beta cyclodextrin for the treatment of NPC1? And most of the individuals on this call know this. When we started looking at hydroxypropyl beta cyclodextrin, there was significant preclinical support. There were in vitro studies, meaning cell culture studies from multiple groups. There were NPC1 mouse studies from multiple laboratories. And then Charles Viet had the NPC1 cat studies. So the preclinical package or support for hydroxypropyl beta cyclodextrin was probably stronger than any other drug candidate that's been put forward for NPC1. That's preclinical, though. The real issue became, okay, it works in the animal models, but how can we treat NPC1 individuals with cyclodextrin? And many of you know we started out using intracerebroventricular route. We're using a myoreservoirs to put it directly into the ventricles of the brain. And we quickly ran into problems. In retrospect, it was probably just real bad luck starting out. But be that it is as may, we made a decision to switch to lumbar intrathecal or delivering by spinal tap. So it's a relatively inefficient way of delivering cyclodextrin to the brain, but it allowed us to start moving forward to see if we could show clinical efficacy. And that's really the other major question, is how can we show clinical efficacy? We did a phase 1-2 trial of intrathecal VTS-270. And we looked at the data at an 18-month time point. This was it was a phase 1-2A trial. All the patients participants were on cyclodextrin. We did an ad hoc comparison to a subcohort of our natural history patients. So we had 14 patients treated with VTS-270 and 21 natural history patients of a similar age. The data from this trial showed that intrathecal VTS-270 had a reasonable toxicity profile. Reasonable is in the context of the disease itself, because as you all know, it is ototoxic. Intrathecal VTS-270 restored central nervous system or brain cholesterol homeostasis. We could tell that from some of the biomarkers that we had worked out in the preclinical models, and we could see that in the kids also. Intrathecal VTS-270 decreased biomarkers of neuronal damage. We've published subsequently that it decreases biomarkers of neuroinflammation associated with the disease. And then from a clinical aspect, intrathecal VTS-270 significantly delayed NPC1 disease progression. The outcome measure we were using was what we refer to as the neurological severity score. This is a score that we put together. We built upon other scoring systems, but it's an attempt to try to describe disease progression in an individual when every individual progresses in different domains. So it was an attempt to try to be able to score patients even though they all had a different sign-symptom complex. So it's an attempt to deal with the variability. If everybody had the same disease progression and the same symptoms, this would be a lot easier. But that is not what we're dealing with in this disease. From these data, you could see that we had a significant reduction in the annualized progression in the VTS 270 cohort versus this group of natural history or observational patients. As I showed you earlier, many of the individuals in our clinical trial are on miglustat. Miglustat is what I'd refer to as a confounder. Okay, in a perfect world, you would say, nope, I want to do an experiment. I'm going to get rid of all other drugs, and I'm only going to focus on one drug. It's not a perfect world in terms of setting up that experiment. As parents, there would have been a lot of reluctance to take individuals off of miglustat. When we did the phase 1/2 trial, we had no idea whether, we'd start it and immediately stop, which we did with the Amaya reservoir. We were afraid if we took patients off of miglustat because it's off-label and you had to fight the insurance companies to get it, that they might not be able to get back on it. At least that was the rationale in the phase 1/2 trial. Later trials, I can tell you from our combined trial, intrathecal and intravenous, nobody was comfortable coming off of miglustat. We actually wrote the trial to have individuals come off of miglustat because we had these data, and we couldn't accrue. So in designing trials, you have to be able to accommodate to some degree what has gotten to be standard practice and for which now a fair amount of data has accrued to indicate clinical efficacy. So that's all I have, and I think Dr. Kravis, will take it for, this is the phase 1/2 trial. We obviously had the phase 2/3 trial that Mallinckrodt conducted that at 12 months was a failed trial. And then Dr. Kravis is going to present some of the data looking at prolonged treatment, or what really is real life data of using this drug. We initiated this study. This was 18-month data, but we're out now 5, 6, 7 years on some of these individuals. Okay.
Okay. All right. I'm going to share can people hear me? All right. I'm going to share my screen. Here we go. Okay. All right. Can people see?
Yep. You're good.
Okay. All right. So we're not presenting the phase 2/3 trial data tonight because you've seen that from Mallinckrodt. Basically, the sham group did not progress very much. They had a miglustat effect in that trial, which is not entirely surprising given the swallow data that Denny just showed you. We have been accruing data in expanded access for quite some time now, actually, starting from near the beginning of Denny's trial. We opened an expanded access, and it was an intermediate patient population expanded access. So that meant that we were allowed to enroll more people into it if people came to us and wanted to enroll. So we enrolled one additional person before the trial, and then we've been enrolling people who don't qualify for the trial ever since. And then after the trial was fully recruited, we started enrolling anybody who who was diagnosed with NPC and had neurological symptoms. So all the people in our study have to have at least some neurological symptoms, but some of them are very early and have less neurological symptoms than the people who were enrolling in the phase 2/3 trial. So this is the data. Now, Mallinckrodt told you that we have data that looks similar to their data. I don't really think it looks that similar to their data. We do have a miglustat effect, which I'll show you in a minute. And as Susan pointed out for Mallinckrodt, we don't have a control group because we've not been enrolling a control group. But, you know, for a long time, I've been arguing that maybe you can't really have a good control group because 1 year isn't really long enough to run the trial. And so we have to use some kind of external comparator with natural history. So this is, we've enrolled 50 people into expanded access or into the VTS 001 trial, which is just basically an open label treatment trial that Mallinckrodt was running. And a lot of the people in expanded access moved into that trial and then they moved back. And so there's been jumping around, but we have a way to keep the data continuous. So 50 patients that have been at least 6 months on treatment, and this is what the data looks like. And remember, Denny said the big standard deviation. So obviously there's a lot of variability in terms of progression rate. And what I'm showing you here is the 5-domain scale, progression on the 5-domain scale, which is the scale that we've started to talk about because there was a study that showed that it contains the 5 domains that are most important to families: ambulation or walking, fine motor skills, cognition, thinking skills, swallowing, and speech. And so, and those are parameters that are really core features of NPC, and they're not like seizures or cataplexy that can come and go depending on what other drugs you're using to manage them. So this is kind of a measure of the core features of NPC and what is it doing. Okay, so the change in the 5-domain scale, this is a change measure. So if people stay at 0, it doesn't mean they have a score of 0. It means they just haven't changed from the beginning of the trial. So this is our data in our entire group. And as you can see, the numbers thin out when we get out to 5, 6, 7 years because there weren't that many people treated back then. But we have a fair number around 3 to 4 years. And on average, these people are remaining relatively close to 0. Does that mean they haven't progressed at all? Not necessarily. They could progress, but it just not enough to raise this scale by a point. So Susan is right that we don't have controls in our group, but we have tried to look at every imaginable control group that we can find in the literature. So this is the control group from the data I'm going to show you in a second of the full NIH natural history cohort. And this group is progressing at 0.75 points per year on this 5-domain scale. And so this is actually data that comes from long-term follow-up. So this is about what the actual progression rate is over this time frame. These other groups are groups that were looked at for 18 months or a year and then have been extrapolated forward. And even though we know that progression isn't linear, it's kind of the best we have to predict progression rate. So this yellow line is the VTS 301 sham group after they adjusted the imputation. And then this green line is the NIH phase 1 2A controls that are going up by 1.3 per year, the ones that Denny just showed you that were being used as the comparison control group for the phase 1 study. Then this 1.5 line is the Orphazyme observational study that is now published. And then also about 1.46 is the rate of progression of people who came into our expanded access. And if we ask what was their rate of progression before they came to us, well, we don't necessarily know what that was. So what we've done is we've said, well, let's pretend that they've been progressing since birth. We're going to take their score and we're going to divide it by their age. And so their progression rate based on that, you know, most people didn't start progressing at birth. So that's kind of an overestimate of the progression rate, but the ACES of this cohort is 1.46. So before they came to us, they were progressing about 1.46 points per year from birth. And then this is the Orphazyme placebo group, which progressed at a rate of about 2 points on the scale per year. So I would argue that our EAP data is actually beating all of those cohorts, basically. And then, so one of the other arguments was that our data is confounded by miglustat. Well, it is confounded by miglustat, and so is every piece of data on NPC on the planet confounded by miglustat, because we can't have a control group that doesn't have miglustat. But our EAP data and VTS 001 has 33% of patients on miglustat, whereas every one of these other cohorts, the full natural history cohort is 54% miglustat. The phase 1/2A controls were 76% miglustat. The Orphazyme observational study is 83% miglustat. So all of these control groups have more miglustat use than our EAP data does. Now, we could have enrolled different ages of patients, different levels of severity. We can't be sure any of these groups are perfectly matched to our group of patients. But in rare disease, sometimes that's basically not really possible. So this is kind of the best we have. We have a number of groups, and our argument would be, well, these are all different natural history groups, and if we can do better than all of them, then it looks like there's a drug effect. Here's our data with miglustat and without miglustat. These are the 17 patients who are on miglustat and the 33 who are not on miglustat. And as you can see, the patients who are not on miglustat are progressing more than the miglustat patients. But once again, is it a fair comparison for us to compare a group that's not on miglustat with all these other groups that have a very high percentage of patients on miglustat? Probably not. Probably really our combined group is a more fair comparison with all these different natural history groups. But I think what this does show is the same thing that the VTS 301 trial shows that Susan showed you, is that being on miglustat plus Adrabetadex is probably better than just being on Adrabetadex. And at least in our data, it looks like it's better to be on, better than just being on miglustat, because these groups are largely just on miglustat, especially some of the European groups. So, so we do think that miglustat is probably an important piece of the treatment of NPC, but we also think there's an additional Adrabetadex effect, at least in our expanded access data. So this is what Denny was talking about before. When the FDA started talking about the totality of the data, we started to think, well, we need to put all this data together somehow. And, we wanted to do this analysis to, kind of show Mallinckrodt that this could be done, and really ask the question, if we put all this data together, what do we get out of it? And can we show a benefit looking at the long-term data for all of the different pots of people that have been treated with Adrabetadex? So the natural history study had 112 people that we were able to ascertain data from. And then we took the patients who were in the phase 1/2A trial, and then we took the patients who were in the phase 2B3 trial, because one of the data cuts from Mallinckrodt, they gave us the actual data. And then we took my Rush EAP patients, where we had 35 patients, and that because this was a little while ago from when we did the data cut for the data I just showed you. So we had a data cutoff of the end of 2019 for the expanded access and for the and for the NIH data, and then we had for the phase 2B3 VTS 301, the data cutoff was March of 2019. So when you think about it, there's actually 2 years of more data that we don't have in this at this point. And Mallinckrodt's going to do a data cut, and I think it would be very valuable to redo this analysis and add the 2 years of data, because if we can show the same thing with 2 additional years of data, it really kind of proves that we are showing a real effect. So we put all these people into one pot, and we did a lot of data cleaning in the NIH database. And then we asked ourselves, what is the rate of decline in the 5-domain scale in the treated and untreated cohorts? And what is the 5-domain score trajectory pre and post treatment if you compare one person to themselves? Okay, so I'm going to show you some of these plots, which, first I'm going to show you the cohort. So basically we wound up with 118 people that we could look at. Now, some of them wound up in both the untreated group and the treated group, because they were people that were in the natural history study and then they went on treatment. So we had 61 people with over 3 observations, which means about like at least a year of data prior to treatment. And we had 99 patients with over a year of follow-up after treatment. And this included 42 individuals who were in both categories. So if we compare the not treated to the treated group, there were more observations in the treated group because we followed them a little more systematically since they went on treatment. The entry age is older for the treated group because a lot of the untreated patients were they went on treatment later after having been in the natural history study. The 5-domain scale was a little bit higher in the treated group, which might make you think they would progress a little faster. And the miglustat use was lower in the miglustat in the treated group, which also might make you think they would progress a little bit faster. So this is the data, and I like to show this because this shows you just how messy the data is in NPC. This is real world data. This is what, when you average out the data and have a nice slide that you show at a meeting from a clinical trial, really the data behind that slide often looks kind of like this in a highly variable rare disease. But we threw all this data into the computer and did a model that asked the question, what happens after treatment? Does the rate of progression taper off? And so the NPC1 progression was modeled with a linear function prior to treatment in the people who were untreated. And we had this rate of increase in the 5-domain scale, which I showed you on that previous plot of 0.74 points per year. Now, this is the lowest rate of progression of any of the studies. And it may suggest that if you follow people long term, and especially if you take anyone who comes in and they're not quite progressing yet, you get a lower rate of progression than you do when you specifically select for people who are a certain amount impaired. But in this data, the average NPC1 progression rate started to decrease after treatment, and the decrease became greater with the number of years that people were on treatment. In other words, it doesn't necessarily mean that your response got better. What it means is that your divergence from what you would have potentially done got better. There were no miglustat effects on this model, and the P was 0.02 for the decrease in progression rate after treatment. So a statistically significant result. Okay, now I'm going to show, so then we said, okay, this looks like this is nice, this is a model, but do we really know that the people the treated people are behaving the same as the untreated people? Because we have this matching issue. So we wanted to ask, in the people who were treated where we had data before they went on treatment and data after they went on treatment, what happened to them in terms of the comparison of their pre and post-treatment rate of decline? So again, we looked at this 5-domain scale, and the number their decline does actually go down. Now, this is what we call a violin plot. And it's like a kind of plot that you use to present highly variable data and kind of real world data. So when the plot gets fat, it means there are a lot of points right there, and that's kind of about where the average or the median is. And when the plot, so when this plot gets fat, it's at a higher number than when this plot gets fat. And that just means that pre-treatment, these patients were progressing at a higher rate than they were progressing post-treatment on average. This doesn't mean every patient. You can see some people go up, and again, not only is the disease variable, the response to drugs is going to be variable. So that makes it even harder to demonstrate a clear treatment effect. But the P was 0.145, which is kind of a trend toward toward a lower rate of progression post-treatment. So then we said, well, all those people in the natural history study who didn't go on treatment actually don't have a significantly different rate of decline from the ones who did go on treatment. So then we did a comparison with all the natural history people and the group of people from the natural history study who went on treatment. And so that allowed us to increase the number. So now we had 61 people to analyze. And then we do have a statistically significant difference. And these are the violin plots of these people. So once again, you can see where it gets fat in the pre-treatment group is higher up than where it gets fat in the post-treatment group. However, this is not people compared with themselves. This is, again, two groups where you're comparing them and you don't really know if they're matched. So then we came up with another way of trying to look at comparing people with themselves. So remember I mentioned that ACEs score, which is your score when we first see you divided by your age. So if you come in the first time you're seen with NPC, you have a score of 7 on this scale, and you're 5 years old, then your progression rate per year is about 1.4 or so. So we took the ACEs score at the first visit divided by the age, and we said, this assumes that the disease has progressed linearly from birth. So most people don't progress from birth, clinically anyway. The things may be going on in the brain, but you don't actually start having clinical symptoms at birth for most patients. So in theory, this would underestimate the actual progression because these patients would have symptoms, so they would have started to go up, and then their disease progression would have been faster than the progression from birth. So we wanted to ask the question, is that really true? Can we see that in a real live group of patients? And so we took the natural history patients who were not on treatment, and when we compare their ACEs score to their rate of progression, we can see that the rate of progression is 0.41 points higher during the pretreatment follow-up, while they were followed at NIH, as compared to the ACEs when they were first seen. And so this is almost statistically significant. Again, there's a lot of variability, which limits the statistics, but it does suggest that the natural thing in NPC is for you to progress at a faster rate than this ACEs score would predict. Then when we take the group of people that's treated and say, okay, now we know what happens in natural history, we're going to compare the treated group of people, all the people from all the studies, to their ACEs score and ask, are they progressing slower than what their rate of decline would have been predicted from birth? And in fact, they are progressing slower. So they are progressing 0.49 points per year less than they were based on the comparison with their ACEs. So now we can say this group doesn't really look like this group, and and even compared to the ACEs, this group is statistically significant at the 0.03 level for these 96 patients. And I think the key here, and this is my last slide, but I think the key here is that in a disease this variable, you really need to get to big numbers. And a 50-patient trial for 1 year just isn't enough to meaningfully statistically say much of anything. You have to go longer, and you have to have bigger numbers. And this is why Denny and I put all the data together into one database to really look at what would we be able to say if we analyze the entire population. And at the time, the FDA was talking about the totality of the data. So this is the totality of the data. Yes, it's variable. Yes, it's probably not perfectly matched, but it might be the best we have. And so I think this is just one model. I mean, there may be other models, but we tried to come up with things that would be reasonable and would allow us to understand if there was a signal in the entire treated population, really over a very long term. Because we have many patients. The average length of follow-up for these patients post-treatment is about 3 years. So it's a much longer follow-up really than for instance, a 1 year study. And just like Jenny showed you with miglustat, you're going to need a study that goes out for 3 to 5 years before you're really going to be able to tell what's going on for sure in a treatment of this disease. What is the long-term impact on the disease? So with that, I am going to stop talking, I think. Yep, and I'm going to stop sharing my screen, and we are going to open this up to questions. And we've talked a lot longer than we were supposed to, but but I think it's fair for the community to really see what is the totality of the data that's out there.
So with that, everyone, again, you can submit questions. There's a couple that I'll read. I'll read two off the bat to you. But if you'd like to speak directly to Liz and Denny, just raise your hand on, I think you go into participants, and then there should be an icon on the bottom, and then I'll click on you and give you a chance to ask a question. Liz and Denny, both, one of the first questions that popped up was about, you were talking about 5 years. It takes, for 3 to 5 years. Denny, you mentioned the phase 1/2A was 18 months. Have you followed those patients to now 5 years and looked at that data specifically versus natural history? And also, do you know how many of those patients were on miglustat versus not?
Yeah, so those patients were in the data that Dr. Kravis showed. And they're out 7 years. Some of them are out 7 years now. We do know, and I realized I didn't say it when I showed that slide. So we had miglustat use in both the control and the treated cohorts, control being the natural history. And the miglustat use was actually similar. It was like 75% and 85%. So it was high, but it was essentially this, at those low numbers, it was essentially the same in both groups. So yes, it's a confounder. I absolutely agree. You can't come up with a group of NPC patients anymore that is not confounded by miglustat. But when you looked at the two sets, it was not a major difference between the two groups. Our natural history has been going on long enough that we have about half the, and because insurance companies would randomize them, we'd have about half the patients on and half the participants not on miglustat. I think you had 54% on Dr. Kravis's slide. So yes, that data is out 7 years in some cases. It's included. Again, it was small numbers are a problem, and therefore we put it together with the EAP data. But if we plot our individuals out, and I've shown this before, you can see the same effect. You can see that there appears to be significant divergence from what we would predict. Another confounding factor, even when we look at that data, and this goes to the variability of the disorder and when you start treatment, individuals in that phase 1/2 study that had very little disease symptoms did better over time than the individuals who came into the study already significantly progressed. So you have then, besides the variability of the disease, you have the variability of where they are in the disease process. And it makes sense. I mean, I mentioned in one of the earliest first slide, we probably have the biggest impact treating earlier. And that would fit with the preclinical models. We know, you can arrest disease, at least in the cat model. Dr. Veit did that. But the biggest impact was actually treating pre-symptomatically. And I think that's reflected in some of the data. We haven't put I've only looked at the phase 1/2 data in that manner, but that's a way that we can look at the entire data set too.
Yeah, I completely agree with that. The people who are in our expanded access who were early symptomatic are in general doing better than the people who were, further progressed. It's just hard to stop a disease once it gets rolling in the brain like that. And the other thing that we have in expanded access that isn't in any other trial is very young kids who are all symptomatic. Every one of them had some kind of neurological disease, but many of them were very early in the neurologic disease, and they were also young. And I think that's an important factor too, because there's a lot more brain plasticity when you're young, and it models what was done in the cat much better than taking people who are older and are partially progressed. And so a lot of those kids, in fact, I think all of the kids that were early symptomatic that we've enrolled who are under age 4 have been doing quite well, kind of as well as you could want. I mean, things may not be perfect, but they're doing very well. And I think at this point, for a large number of them, they're not regressing, and they've reached an age where we can pretty much say they're not going to get late infantile onset disease. I mean, they were already mild enough that they probably weren't going to have early infantile disease. We might need a year or two more to go to say they won't get late infantile disease. Some of them might be going to get juvenile disease, and we need 5 more years to be able to show whether we've prevented that or not. But again, I think this is a group that has done very well, and it's a group that you would predict to do very well. It's a group that hasn't been studied before, so it is an opening maybe to discuss things, for instance, at the FDA about where are different avenues to treatment.
Another question came in, and I'll ask this and then I'll get to Kayla in just a minute. But a couple came in, and they said, and I don't know if you can comment in regards to the FDA and your communications with them, but you showed a lot of variability in some of your slides, but then also in some of your initial slides, it seemed very convincing data, at least to the people watching and participating. How is the FDA been willing to, work with, the community on looking at this data that is varied, but also, there is a lot of convincing information in there, especially when you look at it in a long term. Can you comment on that in some of your communications with them?
My communications, yeah. So I've talked with them periodically about my expanded access. Those conversations have circled around the problems with doing a one-year trial and getting a definitive result, the need for long-term data. We've had all those discussions. The problem that we've come up against is that we don't have a control group that is as good as might be wanted, although I think we do have control groups. And at some point in ultra rare, highly variable diseases where there's going to be responder issues and some patients are going to respond better than others, there's going to be so much variability that you can't have the perfect control group. And so I think in some cases where you just have a case that that you wouldn't really have expected to go that way clinically, that's an important finding, and maybe getting together all the cases that are in that category is an important thing. But the FDA has not, I think the fact that the FDA invited Mallinckrodt to submit an NDA when they knew that the trial was negative is maybe a suggestion that they would be willing to look at some of these more novel analyses. But we have to pin that down. We don't know. We do not know.
Kayla, I'm going to ask you to unmute you. I don't know if you want to share your video or not, but Kayla, can you hear us?
Yes.
Okay. To ask a question.
Can y'all see me? Okay. So one is more of a statement. Cameron, I feel like, was doing well on the treatments, but in the fall of 2019, we decided to step down from every 2 weeks to once a month for treatment. And then shortly after, she got sick, wasn't able to get treatment, and then COVID happened. And for months, she did not get treatment, I think until June. I believe that is correct. But during that time in April, she started having seizures. And we had seen some things that we thought were seizures before treatment at 4 years old, 5 years ago. And then after, the change in the frequency and then being taken off of treatments, these seizures came, and they were intense. So I feel like we need to get that data for sure from the past couple of years, and hopefully until her last visit was this month. So if there's any way for that to happen, I think it needs to, because I feel like it shows that this was helping her. And even if she can't do the treatments anymore, that's everybody else is going to be affected by it. My question is, can we get access to our children's data independently? Thank you.
So the data would be
Muted.
Sorry, Denny, I accidentally muted you. My fault. There you go.
okay. Well, you wanted Dr. Kravis to speak first.
Go ahead.
Okay.
Yes. It would be a matter of what data you're talking about. If it's the data that the treating physician has, that could be released with your permission. And if anybody we would have the ability to receive identifiable data from anybody who was enrolled in one of our trials. From an IRB standpoint.
Yeah, so I think that Mallinckrodt has committed that they are going to give us, I think it's very important for us to get that additional 2 years of data and to be able to potentially redo the analysis with 2 more years of data and find out if we're seeing the same thing. I think those kinds of things are important. but I mean, everyone in my expanded access can have their data anytime they want. We just release it because we aren't dealing with a big company database. But people who are in the Mallinckrodt trial, the data is in the Mallinckrodt database, and it should theoretically be able to be given back to you if by whoever is your site PI.
Okay, another question that came up was the idea around the risk benefit, the negative risk benefit. Can you go into, outside of the hearing, what were the other risks? Was there any other risks that Mallinckrodt was speaking to?
No, they didn't have anything new. The risk is the hearing loss. So what Mallinckrodt changed was the benefit. There was always this thinking that there would be a benefit, and Mallinckrodt just got to the point where they decided that in their trial data they could not demonstrate a benefit. And we've known this for some time because their trial, they first presented their trial some years ago, but they got to the point where that was a definitive decision. And so when you say there's no benefit and you already know there's a risk, then that makes the risk benefit ratio unfavorable. But for people who've already accepted that risk and may or may not be seeing something different from what Mallinckrodt's trial data showed in their own, in the patient in their family, it doesn't mean that the risk benefit ratio is unfavorable for every patient, I don't think. So it's they put that statement out because they're closing the trial, and that's based on their data.
Yeah, the hearing risk is accrued with the first few doses, and we've known that substantially with the first few doses. I would add there is clearly the risk of the post-dose ataxia, lethargy, but pretty much managed either by, you can manage it by dose or managed by interval change too.
Yeah.
Another question came in. Denny, can you comment? Susan, in her presentation in the webinar, mentioned that there were gaps in the natural history data. You kind of talked about, the overall goals of the natural history data when you were starting collecting. Can you talk about some of those gaps that you might be referring to?
Yeah. Again, and that's why I put in what our goals were. It was a discovery natural history trial. It was not designed to have yearly evaluations for everybody over 15 years. That would be extremely difficult in an observation trial. I mean, you have normal things like seizures, individuals get sick, they can't travel, all those things. And if you've already taken your vacation and we cancel the visit, you're not necessarily able to do it again. So that's part of the data. We have other things. We had a volcano. We had earthquakes. We now have a pandemic. So yes, there are gaps in the data, but I showed you the data on the swallowing. You need statisticians that will work with that data. We used the statisticians that did our phase 1-2 analysis had the same kind of gaps to deal with. The statistician that we used for the swallowing analysis had the same kind of gaps to deal with. The statistician that we got involved from, Liz and I got involved from NCATS to pull together the data that we pulled, had to deal with the same kind of gaps. So, it is not a controlled trial where you have nice intervals of data. was never intended to be that. But I think it is not correct to say that you cannot analyze that data and you cannot model that data and extract information from it.
I think Kayla's back. Kayla, do you want to ask another question?
I just wanted to say that, Cameron, one of the reasons we had to exit the trial is because of the swallowing. So over that course of a year, when she was off the treatment, a lot of the time, her swallowing significantly, I feel like, got worse. And so I know that she is not on miglustat, and I'll say that to everybody, but I feel like that also impacted her swallowing. So I don't know what can be done, but I just feel like this is very unfair that we're going off of Mallinckrodt's data from 2019.
Yeah, I don't, it will be interesting to see. I don't necessarily have a good idea of how many individuals had to come off treatment because of COVID. But that may be one way to, if that data is assembled, to look at it in the reverse manner of going on. I just don't know the extent of the data that would be available. You may have a better feel, Liz, because your EAP is much larger than what we were dealing with.
Yeah, I mean, we did not have a lot of people who came off during COVID, although we have had some people who've simply not been able to do the LP infusions anymore. And we've had some who haven't had any immediate change, and some who've gone downhill after they came off. And I just don't think the numbers are big enough for us to say anything definitive. And I think it's going to be like the responder situation, where we have people who are good responders. And if you're not a good responder, then you're probably not going to have a big change coming off. If you are a good responder, then you might. And there's a lot of pieces of that we don't understand yet, because we haven't had a lot of people we haven't had enough people just come off drug to understand what's going to happen to the people when they do come off drug. If they do come off drug. And
if a response is perceived, then it's unlikely that you're going to come off, versus a group that, if a parent's not perceiving a benefit, you're going to come off, because it is not an easy drug for a lot of reasons.
And Kayla, a lot of people are commenting too the same thing about the impact that it's had on JP. Ottinger mentioned the same thing of how it stabilized JP for the last 6 or 7 years. So a lot of people, I'm sure of that. I'm going to switch over. Somebody's raised their hand. This is Galvey.
I should have typed it right, Garland. It's first initial, last name, but it's Garland. I wanted to piggyback off of somebody's question about communications you guys have had with FDA. And Dr. K, you've touched on that. But have either one of you had conversations, or should we have the conversations with them about, other cohorts, other small rare disease cohorts that are out there with the sample size issues and the statistical significant issues? And, what were their successes? I'm sure they faced similar challenges, and, did they have novel ways around them? It just occurred to me to ask if that was ever, discussed, or, if you got any feedback along those lines.
Yeah. I mean, it's not specific discussions with the FDA, but this is not an atypical problem for disorders like NPC that have neurological progression that's slow, later onset. And, the variability we see in NPC is not unique to NPC. You see it in many other disorders, some less, some more. So it's a general problem. It's a problem that the whole field is going to have to eventually come to grips with, because the standard techniques are going to be very difficult to use for drug development. I mean, you can design a study with a 3-year, 5-year placebo group. I can bet that my recruitment for that in a disease like NPC would be 0.
Yeah, I just wondered, because as you talked about aggregating the data and bringing it all together to prove more of a point, I just thought globally of trying to initiate some sort of effort to aggregate the data across
across different diseases. That would be difficult to do. I think the concepts are similar, and we're wrestling with the same concepts that other disease groups are wrestling with. And how can you use historical data in these disorders that and they all vary. So you can't lump them together. They all have, there's a lot of commonalities, but they all differ too. So.
Yeah, I've had those conceptual discussions with FDA surrounding calls with my EAP a little bit. I think we've all discussed this at meetings. Everyone knows there's a problem. It's been hard to figure out how to solve the problem in a way that's acceptable to FDA and also accommodates all of the issues in rare disease. There are some examples of studies where natural history data has been accepted, but those are usually diseases that are evolving much more rapidly than NPC is, so it's easier to see the difference from natural history evolving. So it's absolutely true that we need new models. And I think in NPC, for this drug, we at some point are going to have to go to FDA and pin down what do they need and how long will it take. And that's just something that we're going to have to do, but we have to do that. We have to have a concerted effort to do that at some point, and Mallinckrodt has given us a timeline. So we are going to need to figure out how to best work on it with FDA.
Thanks for the opportunity to ask the question. And I know I speak for a lot of us that we're really happy you're in our corner as we start to think of some action items.
Thank you. Liz and Denny, one question came up about data from the old Michelstadt trials. Have you been able to use that and sort of your analysis? Has any of that proved benefit in some of the data that you've collected?
So we do not have access to that data. That would be Actelion, or now Johnson & Johnson would have that data. I mean, other than what's published.
Yeah. But the concept is good, and there are data sources outside of just data on the 5-domain scale, which is kind of most relevant to the treatment data that we are analyzing right now. But particularly for the little kids that we're treating, there may be developmental data somewhere in these registries, and so I'm trying to find a way to get to some of that. I think it is very important for the field to get together. Mark Patterson's been a little bit closer to that, and I think we do all need to work together to try to pull in some of the data sources that we haven't used yet. And now, it's just a more urgent situation to do it.
Pam Anderson has a question. Pam, I'm going to unmute you.
Thank you. Thanks, Sean. Can you all hear me?
Yep.
Okay. So I have a couple of questions, Denny and Liz. And I think my first question is, in 2018, when we had the PFDD meeting in Washington, there seemed to be a general consensus among the NPC expert clinicians, both of yourselves and Dr. Patterson, that combination therapy was really what this community needed in order to, try and render the disease chronic. And I know there are other clinical trials that are currently going on. There's been a lot of discussion tonight about Adrabetadex and miglustat, but I'd like to hear your thoughts on whether or not you think the other clinical trials are good options for families to move into, to try to now help the community actually get a therapy across the goal line. Because from where I sit as a mom, we participated obviously in the Adrabetadex study, and we have also very dutifully gone to the NIH every year since our diagnosis to help give data to the natural history study. And those efforts, from our perspective now, are not yielding any benefit for the community in terms of an approved therapy or even natural history data that is usable for a clinical trial. And so my question really for not only that Chris and I sort of grapple with in terms of what direction to go in for our girls, but I know I've heard other families grappling with is, should we turn our efforts to some of the other trials that have therapies before the FDA in hopes of getting those therapies approved, so that our ultimate goal as a community that everybody seemed to agree on in 2018 was this idea, this notion of a combination of therapies, multiple drugs treating multiple pathways. So I'd like to hear if you still believe that's the best approach and how you think we go about doing that now. And then also, do you think it's still important for families to come to the NIH and participate in the natural history study? I know a lot of families have done that over the years, but if the data is not usable for our trials, is there another way the community can get involved in helping advance, I guess, the research in a meaningful way?
So I would say, yeah, I'm a little biased here, but I would say yes. I would not state that it's not useful. It has to be used in a correct manner, and it will have to be presented to the FDA, with how it's analyzed, and make an argument that it's a valid way to analyze the data. I think the data that we have on miglustat currently, it's the same data set. I think it's strong, especially when you combine it with Mark's data on increased survival. You can't get any closer to real life data on those. It does have to be, they are not placebo-controlled trials. Okay, and you cannot use the natural or observational study as an equivalent to a placebo-controlled group. But that doesn't, in my mind, that doesn't mean that it can't be used to understand what's going on. I mentioned we do a lot of work on biomarkers. None of them are valid, what would be referred to as a validated biomarker or a surrogate for a clinical outcome measure. However, if you start to talk about combination therapy, trying to understand which component works and to what degree each component works, and we're talking about saying it's going to take 3 to 5 years to figure out individually, it will be very difficult without biomarkers to start making decisions how to put combination therapy together. So I would argue, even from just that standpoint, the observational trial has significance and is relevant to the community.
Yeah, I mean, I'd like to add something here. We all do believe that combination treatment is important and it's going to work better. It's just that every time you get something that takes a chunk off that rate of progression, it becomes harder and harder to show that the next thing works. And so that only increases the need to collect good longitudinal data, because at some point, I mean, real world data involves analyzing what are you on and how are you doing. And so tracking what happens when people get on individual therapies, combination therapies, what are they doing over time with what kind of therapy, collecting that kind of real world data is really important. So having ongoing assessment as you go, as people go through these changes is very important, because we are not likely to be running a placebo-controlled trial for like the third agent that we add on to treatment of NPC if we have two things that are already partially working. So we're talking about very long-term outcomes that can really only be studied in natural history and long-term tracking of patients.
I'm going to let Sarah, you have a question?
Hi. I just, there's been a lot of talk about miglustat on the call tonight and on a couple other calls that we've had. And I just want to say that I really hope our communities could be moving forward and not going back to look at miglustat again. Miglustat is a drug that everyone in the country can access pretty much if they want it. It's approved everywhere else in the world. We know that it's not enough to save our kids. That's why we are looking for more. And it feels a little bit like we're being handed miglustat as a consolation prize of, oh, you're getting this drug ripped away from you. But guess what? Miglustat works better than we thought. It still doesn't work well enough. And it's not enough, and it doesn't compare to Adrabetadex. And it probably doesn't compare to, some of the other components out there too. So I just am, as a parent, a little bit concerned to hear the emphasis on miglustat, especially when this call is supposed to be about Adrabetadex and BTS 270, not miglustat. My other question is there anything that can be shared on this call right now about efforts to maintain access for families who wish to do so, to continue Adrabetadex after October, and what can families do to support these efforts?
So, Sarah, let me just start out. I don't think any of us were promoting that miglustat is the goal here. I think we were using it as an example. I think part of the reason I showed the data on miglustat was to, one, give an example of how the data can actually be used if you have data, even though it has, as was referred to, gaps in it. Okay, so that's an example of how it can be used. I think that, it puts it in that perspective. It also has been put out there. It is a confounder because it does have some efficacy. Absolutely agree with you, not enough. But as Dr. Kravis was just saying, we have to understand miglustat if all the patients are on miglustat to understand anything more that we add to it. So that's the context, not that we're going back to it. Although, I think I agree with you. It has gotten a lot easier to get individuals on miglustat because of the data that has come out. It was not easy when we started, and mainly because of the cost of it. And that's why when you look at my numbers in the natural history, it's only 54%. It's actually gone up. It used to be about 50-50, okay? and that's because we go back far enough. I think this community is going to have, you know, we like the idea of combination therapy, okay? But a reality that you have to consider is what are insurance companies going to do if there is a drug approved for NPC and you're asking them to spend $40,000 a month to add a second drug that is not approved. That might be hard to continue to get insurance companies to pay for two drugs, one approved, one not approved. And that may be a reality that we're faced with as a community. I hope we don't get there. But I think insurance companies will start to bulk. If there is a drug approved, which would be good, we need it. But I wouldn't assume that we can automatically have combination therapy and expect insurance companies to pay for it. So I actually think it's important that the company that was pushing miglustat push it. And I think that, you know, it would be good if they could make an effort to get it approved. So the combination therapy is not a theoretical concept that we're talking about, but is actually a reality for the individuals that are on miglustat now if we get another drug approved.
Yeah, I also think it will be helpful to have data that shows that that if you're on two things together, it's working better than being on one thing alone. I think the data that we have in our EAP supports that. I think that the Orphazyme data supports that. And so this is just that, you know, if you have that data sitting out in the world and it's published, it makes it a little bit easier to work with insurance companies, because sometimes whether something's approved or not, if you can send them a good paper and write a good letter, they will approve it. But it is, you know, that could potentially be an issue. And I think the reason why we wanted to talk about the miglustat swallow study is that, you know, this data has been talked about as having gaps, but clearly it demonstrated a benefit for miglustat in swallowing. And we can use that as a background validation of the idea that we can do a combined analysis and use the natural history data as you know, background data to show that Adrabetadex works, which we then subsequently did. So I think we want to be able to show that the natural history data has multiple uses and can be used to pull out a drug effect, which is kind of where we were with it. And then your other question was, how are we getting this drug after October? And believe me, I've been talking to everyone on the planet who might have some connection to how we might go forward with this drug. I think that, you know, Sean has been talking to people. Clearly, we need a couple things. We need to talk to the FDA, and if we are truly going to do this independently of Mallinckrodt, we will need some form of entity. And I don't know if Sean wants to say anything. I think really the message here is that we are working on it, and we know that we have a timeline. Unless, Sean, do you have more you want to say?
Now, I mean, I'll say not only are we working on it, but working as a community on it. You know, our accelerator's working very hard. So it's in PDF. You know, Phil and Chris and Kristen and a bunch of, you know, a lot of the scientists that have been heavily involved in this work are working hard on it. We have some consultants that are working for us pro bono for free that have been involved in this program from the pharmaceutical area for a while, that have knowledge of the FDA. So everybody's working together really hard to help you guys keep access to this therapy. And it's our commitment to you that we'll just keep fighting. One of the questions for Liz and Denny that came up, that some people had asked Mallinckrodt in the past, and now I think we're going to ask you, is about, you know, the voice of the patient, you know, and how important is that in some of these conversations that happen with the FDA or with Mallinckrodt or whoever, you know, how important is or what can families do to help support this effort? Liz, Denny.
I think we need a concerted effort first to, we can't send everyone to the FDA with a pickaxe. You might want to do that, but we can't do that. We have to, organize and have representatives of the community talk to the FDA, potentially have the experts talk to the FDA, have some data in front of the FDA, and then just ask them, what do we need to do? And if it turns out that there, needs to be multiple people go there or do a Zoom call or whatever to present cases, then that might be something that the community can do. But I think we really have to figure out what would be useful to help with this effort at the FDA, which is going to involve at some point a conversation with them.
I think some of the families asked a question about access to IT therapy if they can't get it at their clinical site. Do you have any?
Well, there are many layers of that we do know about. We know that the J&J INDs, which were not included in the data that I showed because they're not in my expanded access program, we know that they are on a different timeline from the Mallinckrodt INDs, and I do have potentially some information about that. I know we are working on trying to find solutions. Some clinical sites, their IRB may say that they can't go forward, or their doctor may say that they can't go forward. I think in that case, you would need to contact, if you want to go forward and have the ability to travel, I think you just need to talk to me, maybe. There could be places that you could go if your site won't continue.
A couple parents have mentioned Denny specifically. When it comes to the natural history data, and when we have these conversations with the FDA, just they really want you involved, especially because you're the most familiar with a lot of this natural history data. I think they were a little frustrated with some of the comments made by Mallinckrodt in regards to it. So just your commitment to continue to be involved and help assure that there is a lot of value in there.
Was that a question or a comment? Sorry.
And I just want you to confirm that you're committed.
Yeah, well, we've been at this for a while, guys. I can think of easier things to do. I think everybody that knows me knows I have a basic lab associated with it. Mice are a lot easier. So guys, we wouldn't be, this has been a long haul, and people have been involved with cyclodextrin, that there were a number of times when I thought it was on life support, including when I had Omayo reservoirs infected when we initially started. So we've got a dedicated team. Believe me, we are frustrated. We're not looking to leave the community, and that's Pam. That's why I'm saying don't kill our natural history trial. That'll keep us going and keep us engaged and allow us to look at new things. So we are there. I'll be up front. I'm in a different position as a federal government employee. When you talk about petitioning the FDA, I am not allowed to petition another part of the federal government on part of a third party. I can defend the interests of the NIH, and I can provide expert information to them. So, and that we've done in the past, and that we will continue to do. NIH has a stake in seeing this move forward if we can get it moving forward again.
When we get it moving forward, right?
When we get it moving forward, yes.
I'm going to let Jay as a comment. I'm asking.
Is that for me?
Jay.
In Mallinckrodt's financial news that's out on the web on January 28th, they put out an article, When Drug Development for Rare Disease Hits a Setback, Parents Were Stung. A couple of the sentences in there. Mallinckrodt performed a reanalysis of the trial results in patients who received the drug under compassionate use. We were not able to demonstrate a benefit with Adrabetadex, Dr. Romano said. So Romano saying that with all of Dr. Kravis's information, they couldn't see any improvement. That's one statement in here. And he also says it's not practical to conduct a trial. And I think we're dealing with a company that we're not going to win with. I think of the families that flew from California every 2 weeks for years to do the safety data and everything else. And then the last sentence I just want to read. Mallinckrodt said it plans to share the Adrabetadex data at scientific conferences, adding that it is open to licensing the drug to another entity that might want to take on its development. So they're basically a bankrupt company that's still being sued for nuclear waste dumping, shareholder fraud, you name it. We have to get the drug away from this company. The United States government, through the NIH, through taxpayer dollars, and through the families of dying children, basically developed this drug. And we need to take it back and put it with somebody that wants to do something with it. Thank you.
Yeah, I don't know if Liz or Denny, you want to comment, but yeah, I think Mallinckrodt, they definitely committed to licensing and sharing this data for the public. And I know that's going to be conversations we have with them going forward.
Yeah, they do appear to be willing to give the drug to another entity if that entity can be developed and funded to support it. I did that article was by Amy Marcus, and unfortunately she got me on a day when I was rather busy, so I didn't have time to interview with her. But the statement that they analyzed the EAP data is, they had it, we gave it to them, but they didn't truly, they were very focused on the trial data. I don't believe they did justice to the EAP data.
Nor justice to the natural history data. They wanted to use it in one approach, and that approach is not going to work with that data set.
Right. We have a different analysis and a statistician who looked at it through different models. And I think, we need to find out what kinds of models the FDA will allow us to use.
Accept.
But the data can be used. It's just a matter of looking at it like real life data instead of like a trial.
So I think we've gotten through every question. I apologize if I meet it, but I'm going to allow Denny and Liz to answer one more question, and I'll have some comments to at the end. But, Liz, you presented and Denny, you presented some really good arguments, especially with your data of the effectiveness of this therapy. When you looked at it over a number of years, where does the community go from here? You've touched on it a few times. What are your thoughts on that?
It really, I think the key, it's not an easy problem, first of all. The key will be identifying an entity that has the ability to pick it up, assume manufacturing of the drug for supply, assume regulatory functions, and assume monitoring functions. If nobody was on the drug, this would be relatively simple. and we wouldn't have a drop dead stop date. We have a lot of individuals on this drug where you're trying to meet a stop point of 9 months. So it makes the problem more difficult, doesn't make it impossible, but it will require an entity that has the capability to arrange for manufacturing, to meet the quality controls, to arrange for regulatory, and arrange, and do appropriate monitoring of the individuals who are on the drug at various sites. And I think, the discussion right prior to that was that everything we've heard from Mallinckrodt is that they would be open to transferring. That would be the one first, that has to be arranged, because if an entity does step in that could do that, they have to be able to get standing with the FDA, and the FDA standing with the FDA will be through the IND that Mallinckrodt currently has.
Yep. So we need to talk to FDA, get Mallinckrodt organized to do what they've said they're going to do, and create an entity that can distribute the drug and maintain the appropriate regulatory items. And then figure out from the FDA what is the time frame of treatment to give them, what outcomes would they accept for an approval. So it's a tall order. But I think we have a lot of people working on it, a lot of people who are quite enthusiastic about making this move forward, and hopefully it can be done.
Well, I'll conclude that I just want to thank everyone on the webinar today. And I'll conclude saying that it is a tall order, but we're committed to just working extremely hard and we'll continue to fight to get this over the goal line. We, as Liz and Denny, we're working hand in hand as a community with some of our community partners. We have expert consultants that have volunteered their time, and they've already spent a significant amount of time over the last couple of weeks giving us their thought, helping us guide us with a plan to move forward on that. There'll be additional opportunities, for people to present this, talk about the data and present this, talk about our conference. I know the NNPDF has their conference and has a webinar coming up in a few weeks. So there will be more opportunities to keep this conversation moving, but we are working hard, and we do believe everybody here has a voice in this. So especially, we're going to be fighting for these children and for the patients, and we do truly believe that all of your voices will help with this. So that is our commitment to you. With that, I thank Denny and Liz for, again, taking a few hours out of your time to talk and present and show us the data and the work you've been doing. Thank you to all the families and others for joining us this evening.
Sean, I want to play a song.
You want to play? We'll exit with this song.
Okay.
Play. But again, thank you. This is recorded to everybody tomorrow. Okay, so please have a pleasant evening, and know we should keep fighting for you. Thank you.
Okay, I'm playing the song. I also think the really young kids getting together their data is going to be key, because that's a group that hasn't been studied and sort of poisoned by the trial. Anyway, this is my song. Oops. Okay. So we're not giving up.
All right. Everybody have a good evening.
Okay.
Thank you.
Bye, everybody.